Welcome, everyone, and thanks for taking the time out of your day to join us this afternoon. I'm really looking forward to today's conversation with our presenter, Dr. Samra Sahlu. But I'm going to start with a couple of housekeeping items before offering a land acknowledgement. First, I'd like to request that everyone keep their video and microphones off during the presentation. This will let you make use of the hide non-video participants feature, and that'll spotlight the speaker for you. We'll set aside about 10 minutes at the end of today's presentation for questions. So you can pop those questions in the chat if you would like, or hold on to them for the end of our presentation. My name is Natalia Mason. I'm the Community Engagement Specialist in the Division of Social Accountability. I'm joining today from the College of Medicine's main campus, which is in Saskatoon on Treaty 6 territory and the homeland of the Métis. Like most of you, my life has been enriched and sustained by the care and stewardship of these lands by Indigenous people. So I'm extremely grateful to be able to call this territory home. The Division of Social Accountability undertakes its work from an intersectional lens, which considers the relationship between power and varying forms of oppression. In a Canadian context, it's always critical for us to be able to reflect on the historical and ongoing impacts of colonization on Indigenous people and their traditions and communities. My father immigrated to Canada from the Caribbean in pursuit of better opportunity for himself and his descendants. My mom's family were farmers in the northeast part of the province, and I recognize that the opportunities that have been available to my family have not always equally benefited the Indigenous people who have cared for and stewarded these lands since time immemorial. So it's a colonial history that brought me to our conversation today, and I'm sure that that's also something that Dr. Sahlu will be touching on as well. But it is with a spirit of reconciliation and a commitment to good relationships that I center my work at this university. For those of you who don't know, the Division of Social Accountability is a division of the College of Medicine that's dedicated to health equity, anti-racist education, community-based research, advocacy, authentic partnerships, and the health needs of underserved and marginalized communities. So these webinars are primarily offered to support our students, our faculty, and our staff who are learning in the College of Medicine, touching on some of the priority health needs of those in our community. But our webinars are always open invite, so please spread the word to any friends or colleagues who you think might be interested. This month, I'm extremely excited to be welcoming Dr. Samra Sahlu. Dr. Sahlu is an adult psychiatrist who splits her time between Saskatchewan and Tkaronto. She was born and raised in Treaty 4 territory and is a proud graduate of the St. Augustine Community School in Regina. She completed her medical school and residency training in psychiatry at the U of S and was honored with an award for her advocacy efforts during training. She completed the Diversity Leadership Fellowship through the American Psychiatric Association based in Washington, D.C., where she served on the Council on Minority Mental Health and Health Disparities. She's currently working with a small group from the council on a short documentary about the legacy of Black psychiatrists from the 60s. She's practiced psychiatry in hospital, outpatient, ER, and correction settings, and her professional interests include advocacy, mentorship, and cultural psychiatry, transgender and gender diverse care, community engagement, and collaboration with the arts. She's proud to be part of the SAPACCY. Did I say that acronym right? You can fix it for me after. Substance Use for African Canadian and Caribbean Youth team at the Center for Addiction and Mental Health, and the Mobile Crisis team supported by TAIBU CHC in Scarborough. She commutes back to Saskatchewan to provide gender-affirming psychiatric care. And I have had the good fortune to befriend Dr. Sahlu, both personally and professionally, over the last little year and a bit. And she was our very gracious host for a number of different panels at the Black Physicians of Canada conference. And I think she's such an engaging speaker. So I'm incredibly grateful to have her joining us today to share all of her expertise. And I hope you'll all welcome Dr. Sahlu, and I will pass it over to you.
Thank you. Thank you so much, Natalia, for the warm and generous introduction. And thank you to the Division of Social Accountability for putting this on, and to all of you who decided to join today, wherever you are on your screens and for taking some time to sit and to be together and to do some thinking and some learning about Black mental health histories and futures. So I want to welcome all of you. I'm going to start with a story. So I decided I wanted to be a doctor around age 6 or 7-ish. It wasn't my first choice. The first thing that I wanted to be actually was a nun. And that's because there was a nun that came to my grade 1 class. And she was so nice and so kind and gentle. And I was like, okay, she's nice. That's good. I want to be nice too. So I want to be a nun. But then I found out that we weren't Catholic. So that kind of took that opportunity off the table for me. So my parents are Ethiopian Orthodox in terms of religious background. They came as refugees in the 1980s from Ethiopia via Sudan, and then came to Regina, Saskatchewan. And so they let me know we're not Catholic, so I think the nun idea might not work. Okay, so I rolled on to the next nearest role model that was in my vision, and I saw a teacher. So I was like, okay, my teacher's cool. My teacher's nice. I could be a teacher. But then something else shifted. There was a small medical clinic a couple blocks from our house, and there was a wonderful doctor who worked there. His name was Dr. Burke. And Dr. Burke was originally from Jamaica. He was actually an internist and a family physician, and he moved to Regina in the 1970s, and he had been providing care for so many people for so many years. And we went to him with all our questions, concerns, anything that we were worried about. We knew we had just a few short minutes away, someone we could talk to about all of those things. And I didn't just like him because of the candy that he had in his office. I mean, the candy was a bonus, but it was his calmness, his ease, the sense of comfort that he offered all of us, while always giving information and knowledge and just seeming like a wise person that made me think, this is something that I want to be able to do. This is someone who I would like to be like. So that was it. I had decided, I'm going to be a doctor. And I didn't know about call schedules and student loans at that time, which was probably for the best. But my mind was set. So that's part of how I ended up here today. So I wanted to dedicate today's talk to Dr. Burke. And this is a picture of him. Unfortunately, he's since passed on, but I wanted to dedicate it to him and to so many like him who came from so far away and have worked and cared for others here and across the world. So people who have come from all over and care for us over many years. So I want us to also take a minute as we think about those who have impacted us along our way to remember the quiet but profound impacts that we have on our patients and their loved ones who witness us as we move through our work. I think sometimes we forget just how much we are being witnessed, and it's not often just the work we do, but how we do it. So whether that be our students, our colleagues, our patients' families, our patients' loved ones, I think we need to remember that we are being witnessed and to carry the responsibility that comes with that. So none of us would make it through medicine without support. And so I have to acknowledge as well all the many supports I had, not just family and friends, but also teachers, and especially at my elementary school, St. Augustine Community School, which I always have to mention because it's just a few blocks from the General Hospital in Regina. And so if any of you have been to Regina or are currently based there and have done training at the General, you kind of have a sense of what the neighborhood is like. And this stage of the neighborhood now is actually a big change from how it was 30 years ago. So you can use your imagination to kind of see what it was like. I can remember, just to give context, like the city police actually moved like a small branch next to our school because of how much trouble our kind of age mates were causing in the neighborhood. And I mean, it's since gone now, which I think is a sign of gentrification and changes in the neighborhood. But it was an exciting place, but it was also a place where I was cared for. And I remember one of my teachers, actually my grade 4 teacher, Mr. D, he used to call me Dr. Sahlu even then, even in grade 4. And that kind of support, I think, is so special and made me unshakable moving forward. And so just imagine I was this small girl, but there was this big, tall, proud Indigenous man who always called me Dr. Sahlu and instilled in me that this is what, if I wanted to be this, that this is what I could be. And so when we think about Black and Indigenous solidarity, that we can think about these connections that happen in Saskatchewan, both between groups, but also with groups of growing Black and Indigenous populations as one group of people who share multiple cultures within the same family. So something to be mindful of as we reflect on differing histories of colonization, but shared ways that we can support each other. So where are we going to go today? We like objectives, so we're going to start in the past. And pasts, I would like us to learn elements of Black mental health histories and some elements, not all. This is a short talk today, so we won't be able to cover everything, but I would like to give us at least some grounding in some history that I think provides important context. Presence, I would like for us to appreciate current data on Black health and to get a sense of where to look for data if it's something that we're interested in finding. And then finally, I'd like to close by looking at futures and considering connections to Black mental health futures and where these connections may take us. So I want to take a moment to talk about plurality, meaning more than one. And you may have noticed in the objectives, I use the plural form, pasts and presents and futures, because we are not a monolith. As Black people, we can come from so many different areas of the world, so many different stories, so many different socioeconomic backgrounds, that it doesn't make sense to flatten all of that depth and complexity to one thing. There's no such thing as the Black community singular. There are multiple Black communities. And while we can share similarities across these communities, doesn't necessarily mean that everyone feels the same way about various topics or that everyone reacts the same way to certain situations. So with that in mind, I want to think of plurality, think of complexity, think of different ways that we share similarities while respecting differences. I don't want to perpetuate stereotypes or to give the impression that there is only one correct answer for all Black people. I think that would be an inaccurate and unhelpful way to present talks about being Black in medicine generally. So I want us to remember that there are many forms and to keep that in mind as we go forward. The other thing that I want to acknowledge as a limitation is that I'm going to be talking about mental health mostly from a psychiatric lens. I'm not going to be talking about traditional forms of medicine because that's not my area of expertise. I'm going to be talking about formal mental health structures in terms of what has been medicalized, what we know as psychiatric institutions, how they've developed into what we know today. So I want to recognize that this is, again, just a part of Black mental health pasts. It's not the total story, but from where I sit today as a psychiatrist, it's something that I can share with you based on where I've been. So historically, we know that medicine in general and psychiatry more specifically has not had the greatest reputation with marginalized populations. In the context of Black people, specifically African American people, those who are in the United States as a result of the transatlantic slave trade, psychiatry was often used as a tool to further oppress people and to justify slavery. And so it then follows that people who heard about these diagnoses being used to justify their own mistreatment would have a mistrust for a health system that's supposed to talk to them about how they're feeling or how they're thinking or who's sane and who's not. So I wanted to share a couple of snapshots of what that looks like. Has anyone heard of drapetomania? This one's no longer in common usage, but this idea that if an enslaved person were to run away, they must have a mental illness that's causing them to flee, because why would you ever want to run away from being a slave? There must be something wrong with you. And the diagnosis that was given for that was drapetomania. Dysesthesia aethiopica was the title given to the term of an enslaved person who didn't want to work. If you were refusing labor and being vocal or not being vocal about engaging in physical work, the idea was that this was an illness. Clearly you were unwell. And then this was the title that was given to it. Protest psychosis is bringing it a little forward, more forward into the future by about 100 years. So in the 60s and 70s, there were high rates of Black people being diagnosed with psychosis. And people thought, well, you're out in the street, you're marching, you're very angry about these things that are going on in the world, but the way you're expressing it is wrong. And the way you're expressing it must be due to the fact that you have a mental illness. And so oftentimes people who are involved in activism were often unfairly included into having psychotic features when in fact they were agitating for civil rights. And so there's a great book by that same title if it's something that you're interested in reading about. And I think elements of that persist today when we talk about pathologizing reasonable responses to injustice. The next bit I wanted to mention was Negroidism, was just the idea that being Black in general was a disease. And so that was just it. That was the disease. There was no other characteristic with it other than the fact that just being Black was the problem. And so we think of these things now as pretty nonsensical, but actually the person who came up with that is Dr. Benjamin Rush. And he, up until very recently, was on the emblem of all of our gear from the American Psychiatric Association. So he's considered like one of the founders of modern psychiatry and certainly American psychiatry. And so every time we would go to conferences, and these would be the big annual meetings that are the largest gatherings of psychiatrists in the world. There would be meetings about what should be and shouldn't be in the DSM. Like, this is a very important organization. And this emblem was always on the book bags, always on the letterhead, always on the envelopes. And so just a few years ago, after many Black psychiatrists had raised their voices about this, the APA did decide to change it. And now these changes don't change the deeper issues, but I think there is something to be said about symbols and semiotics and how we present ourselves. So about 3 years ago, the APA did offer this apology to Black, Indigenous, and people of color for its support of structural racism in psychiatry. And so I think it's important to consider, what larger organizations have said they are going to do to amend some of the harms that have happened in the past. So what they have said is that they are committed to identifying, understanding, and rectifying past injustices, as well as developing anti-racist policies that promote equity in mental health for all. It's important to note that early psychiatric practices laid the groundwork for inequities in clinical treatment that have historically limited quality access to psychiatric care for Black, Indigenous, and people of color. And so these actions connect with larger social issues such as race-based discrimination and racial injustice, and have furthered poverty along with other adverse outcomes. And I think being able to note that connection to outcomes is so important. We know when we're talking to physicians, we want to see the data, we want to see results, we want to see outcomes. And when we are able to demonstrate that there are statistically significant disparities in outcomes, we're better able to advocate for change. So I think noting that there is a dark history of unethical research practices, poor clinical practices, disparities in outcomes in the past and currently is so important when we are looking to make change within our institutions wherever we are today. So you can refer back to things that institutions have said they will stand by. So as part of the fellowship Natalia had mentioned that I did in the APA, it included working on the Council for Minority Mental Health and Health Disparities. And that meant that you got to be in Washington, DC for meetings and fly to different American cities where meetings were being held, and you could meet with all kinds of psychiatrists who had been working around the country for years. And one of the things that came from being on that council was an idea to make a short film that would document exactly what had gone on in the 1960s in the organization to cause a big shift. So to let you know a bit of what had happened, 1969, there was an annual meeting of the APA. And at that time, Black psychiatrists felt that they were not being heard, that the issues of the day were not being adequately addressed by the organization that was supposed to be there for them and their patients. And so they stormed the annual general meeting with a big list of demands. And the ripple effects from that list of demands led to a lot of institutional changes that I'm going to talk about a little bit more as we go forward. But I'd like to share at least a small clip with you, the trailer of the documentary, which we still haven't completed due to various factors, but I'm going to share just a bit of it with you now here.
Black members of the APA were very much concerned that we were kind of going through the 60s and not addressing the issues that were facing Black America.
1969 was the time of the big riots in the urban parts of the country. And our response was what we put forth as Black psychiatrists.
People went to the board meeting and started making demands. I mean, the 60s were great for that.
You know, the kind of white, male-dominated board was not addressing the concerns of the Black community and other marginalized communities.
It was also a shift towards recognizing the need for making sure that African Americans had access to services, which was pretty much neglected.
There was not any way within the APA to bring those issues to the forefront.
The Committee of Black Psychiatrists were paying attention to Black mental health issues.
There was a growing appeal to say, we're paying dues, we deserve some representation, which led the way for all the other ethnic minority groups to come in.
So as I've learned more about implicit bias and discrimination against women and minorities, the more my eyes are open to what happens in a day-to-day.
This is what mirrors the entire country that we are taking care of and that we need to take care of better. And it's through committees like this that expand our awareness of the importance of diversity.
The LGBTQ community has a severe lack of providers that are knowledgeable. You need gender-affirming therapists, you need gay-affirming therapists, you need people that aren't going to try to convert people back to being straight or being cis.
We must advocate for mental health, period, but also for mental health for people who have been chronically traumatized for generations.
So now we've got these fantastic young leaders that are changing things.
Look at the plight of minorities in our country. We still have a long way to go.
Thank you for giving that your attention for those moments. And we're still working on it, hopefully to present a finished product at the upcoming APA meeting in New York in about 3 months. Hopefully things will be good to go by then. But there are so many elders in that clip, in that short clip even, that have since passed since filming. And so I'm so glad that we were able to take that time to sit down and gather those histories. One of them that wasn't in the clip is Dr. June Jackson Christmas, and I've included her obituary just recently, as she has just recently passed away. And she was such a phenomenal person to talk to. If you can imagine going to medical school in the 40s, if you can imagine becoming a young Black woman psychiatrist in New York City, if you can imagine running all of mental health, being the director for mental health for the entire city of New York under several mayors, as the byline explains. She was wonderful to talk to, and it was so humbling to hear, how much she and so many others that I got to sit with have lived through. So I would really encourage, as African peoples, we do have a history of oral knowledge, but also of recording the oral knowledge and the stories, because there's just such an incredible human element to all of this that I think we lose without getting that captured. One of the men in the picture was Dr. Jeffrey Akaka. He's in the short clip of the documentary. He was sitting there with a tie and talking about how important it is to have solidarity across groups. And so he is Native Hawaiian, and his family actually had such a wonderful history when we're talking about Black and Indigenous solidarity. So if you think back to famous pictures of Dr. Martin Luther King marching in Selma, there's often a picture of him marching with a lei, the flowers around his neck. And Dr. Akaka shared with me that those flowers were actually sent to Dr. King by Dr. Akaka's father, who was a spiritual leader, and they had been friends in correspondence, sharing solidarity for the civil rights struggle. And so that very famous picture has such a close family tie to Dr. Akaka, and such a beautiful way to think again about shared solidarities between groups. Another iconic person that we heard lots about in the filming of this was Dr. Chester Pierce. And so I had noticed this name come up a lot at meetings, and Dr. Pierce was alive when I was involved, but had again since passed. And I don't think it's possible to kind of overstate his impact. Dr. Chester Pierce has a very interesting life, which is well documented. If you're interested in reading biographies or descriptions, there are several accounts online as well as books. And so he was a professor of psychiatry at Harvard, and he actually started at Harvard when he was a football player, and he was the first Black football player to play south of the Mason-Dixie line. So if you can imagine, there was a time when American college football did not include Black people, which I know is hard to think about, but he was one of the people who were out there when that was changing. And so he went on to have such a big impact on global mental health, of writing, of publishing, of teaching, that so many people across the United States and really the world attribute lines of thought to things that Dr. Chester Pierce had worked on. If you've heard the term microaggressions, then you've heard of Dr. Chester Pierce's work. He was the first to coin that term. And of course, later on, it has taken on additional meanings and changes through time and through shifts in culture. But he was the one who initially thought about how do we give language to these little slights that happen every day that affect our dignity, affect our well-being. What do we call it? So Dr. Chester Pierce is certainly a legend in that regard. You also have come across parts of his work if you have ever seen these guys. So I think it's interesting the different ways that Black psychiatrists have come up in history. And Chester Pierce was an advisor to Sesame Street, which was initially designed to bring education to young inner city children who might not have the enrichment programs that children in other areas would have access to. And so the idea was television was this equalizer. And so there was a group of psychologists and child educators who are working in the northeast part of the United States, of which Chester Pierce was a part. And they had designed Sesame Street. And if you think about it, think of how it looks. It kind of looks like inner city New York, the brick buildings, the bodegas, the neighbors talking to each other. And that was the idea that if children could have exposure to diversity and to learning in ways where they often see people who look like them and people who look different from them, that there would be an overall benefit. And so that's, again, a legacy of Black mental health histories. There were Black people who were also involved in studies, the famous study that overturned Brown versus Board of Education, which was the challenge in the United States to integrate schools. And so this doll test, you may remember hearing about it, where psychologists would present to Black children and white children a Black doll and a white doll and ask them which one is more beautiful, which one they would like to be. And using the results from that test showed how it was, how Black children were being negatively impacted by racism. And so this again shows how mental health data studies have wider impacts on society. You noticed also in the clip, in the trailer, that there was also mentions of LGBTQ changes and within the APA. And I think it's important to talk about how these things came about. So homosexuality was actually listed in the DSM until 1973. And so 1973 isn't that far away from 1969 if we think about when the psychiatrists stormed the meeting. So what had happened in that in-between part was, as they had said, more and more groups were organizing. And there was a section of the APA, which affectionately became known as the Gay PA, that invited the then president of the APA to attend their sessions and even to attend their after conference get-togethers. And there was a very brave young resident at that time who actually gave a very famous presentation, but in a mask, behind a mask. And you can look this up to see. And he presented papers with medical evidence as to why homosexuality is not a mental disorder and how it's harmful to have it listed in the DSM. And then through all these changes, through different groups having more access to speaking to people in power, and for people in power being willing to listen, this changed in 1973. So there's kind of a whole ripple effect of changes that happened from people speaking up and from people in power being willing to listen and to take action. One thing that I wanted to briefly mention is this very peculiar phenomenon I've noticed of Frantz Fanon. And that is that Frantz Fanon is completely absent from medical school curricula. I would love to do a study, to do a survey to see how many times he actually comes up in medical school curricula, because I cannot get through a single social studies or humanities course or talk without some kind of allusion to Frantz Fanon. It is difficult to describe how big his impact is on thought in the humanities, and specifically when we're thinking about anti-oppression. And so he's so prevalent in so many fields. And he was a psychiatrist, but we never talk about him in medicine. We certainly talk about a lot of other famous doctors, but he doesn't come up in medicine. But if you went across the street to any of the other departments, Frantz Fanon is talked about so much. So I think it's important to note the big impacts that psychiatrists and Black physicians have had, both within medicine and also beyond medicine. All right, so that was some elements of mental health pasts and what that'll look like. I want to bring us now back into the present and kind of see what current data is looking like on Black health and where we can find data if we are looking for it. So thanks, Natalia. I'm glad to see that Chester Pierce is getting spoken about in your training. That's great. So the World Health Organization published this already 10 years ago already, noting the social determinants of mental health. And so what are the main findings? That certain population subgroups are at higher risk of mental disorders because of greater exposure and vulnerability to unfavorable social, economic, and environmental circumstances, interrelated with gender. Disadvantage starts before birth and accumulates throughout life. And a significant body of work now exists that emphasizes the need for a life course approach to understanding and tackling mental and physical health inequities. This approach should take into account the differential experience and impact of social determinants throughout life. And so when I was mentioning the importance of plurality before and recognizing the complexity of differences, this is exactly where it comes in. So you may have heard about the ACE study, and when I look at this triangle, it's also kind of what I think of. It's the ACE study in a way, looking at the different ways that early stages of development have impacts on later stages. And what's important here is this arrow at the bottom that goes back, the perpetuation of inequities, that intergenerational transmission that goes from those who are older age to those who are younger age, that help perpetuate things within a system. And so these can be positive things, these can be negative things, but I do like this figure for helping to kind of crystallize what that might look like. So how does this play out clinically? Well, we know that it will impact how patients show up to clinic, the ways in which patients show up to clinic, showing up later, showing up earlier, what demands patients may, or complaints patients may present with. There's also the kinds of clinics that patients are be able to find in their neighborhoods, and the kinds of hospitals, the kind of care, so that's the clinic itself. But then there's also our own interpretation as healthcare providers, and therefore interventions. These are influenced by biases, conscious and unconscious, our own prejudice, and this leads to racially disparate clinical decisions. And this is where we see differences in outcomes. So these are just some examples of what differences in outcomes look like. There are various studies of this across disciplines, but here's one example from Academic Psychiatry, published about 3 years ago. And so in this particular study, they were able to see racial implicit associations that were measurable and statistically significant among medical students and psychiatric physicians when looking at patients who they were trying to categorize if they had psychotic versus mood disorder, or if they were the word compliant versus non-compliant, which is we know is a controversial term based on racial groups. And so we can imagine what would happen if someone is categorized as having a psychotic disorder versus a mood disorder, and adherent versus non-adherent, what that means for the kind of care and kind of treatment plans that are formulated after. Black Health Alliance is a group in Ontario that does a large amount of work on studying Black health outcomes. And so one of the studies that they had completed showed the following statistics: that people of Caribbean, East, and West African origin in Ontario have 60% increased risk of psychosis. So that the question is there, is this organic psychosis, or is this being labeled as psychosis? Black Ontarians of Caribbean descent have 2 times the time delay in getting to evidence-based services than those of white European descent. Black Ontarians experience a higher level of aversive pathways to care, that being emergency room, ambulance, or police, compared to those of white European descent. And Black Ontarians experience higher rates of restraints and confinement under the care of mental health and addictions. And so all of these things impact the thing we care about, which is outcomes. And so we have the statistics that show that there are differences in what people are experiencing, both when they on their way to seeking mental health care, while they're in mental health care, and the after effects. So this is the Black Health Alliance website. If you want to have a look, I would really encourage you to see what they've got going on. They've got so many wonderful projects, and they're a very strong team, and I'm quite grateful for all the important work that they're doing. Another study that was published that will be helpful is this one from the Government of Canada's website. So this was published in 2020, Social Determinants and Inequities in Health for Black Canadians, a snapshot. And so this is not necessarily just related to mental health, but a larger overview about health inequities. And so if you are looking for data, I would recommend this document as something that would be both helpful and Canadian specific. The CMAJ also has an issue from 2022 2 issues actually focused on Black health. And so you should be able to find these through your own membership or your library if you don't have a membership. But there are multiple wonderful articles done by colleagues about addressing anti-Black racism in Canadian health. There's also a new show on CBC that I wanted to mention. So this is Amanda Paris, who's a wonderful creator in media, and she has an episode on this new show called For the Culture about Black maternal health crises. And so I don't have time to play a clip from the episode, but it's talking about the differences in outcome for Black mothers and birthing people. And I think it is so important to talk about because we have exposure to what happens on the early stage of the life cycle as infants, and you have adults impacted, you have children impacted. It's really an important snapshot of the different ways that racism kind of permeates clinical decision making. So does anyone know who this is? Does this face look familiar to anyone? This is a young man by the name of Samuel Uko, And he unfortunately died in 2020 after presenting to the emergency department in Regina looking for mental health help twice in one day. And so he was taken out of the emergency department at his second visit, and he walked around the area around the hospital, around downtown Regina, and then he ultimately drowned in Wascana Lake a few hours later. And so this story became synonymous with other tragedies that have happened in emergency departments across Canada, like Joyce Echaquan, an Indigenous woman in Quebec, and many others across time. And so I wanted to take a moment as we're talking about current data and differences in outcome that we reflect on this person who lived where we are living in Saskatchewan. And I want to share this short clip there. It's about a memorial walk, and I'm sharing with permission from his family so that we can have a sense of the impact of this on the community.
People thought that you hear stories like Eric Garner, Tamir Rice, Sandra Bland, and you say that would never happen here. Things like that don't happen here. Ultimately, we see that there are systemic issues put in place for people who look like us, no matter what, not to succeed. And so our parents, they ask us to conform to the society. They ask us to give up a lot of who we are so that we could be able to be accepted in the society and also succeed. He's a personification of all of our fears, that even when we do that, we're still not going to get accepted. As a community, we have to come together and show the family that Samuel was accepted in a large part of this community and establishing the change that is going to happen.
So thank you for taking a moment to watch that. I want to give us a moment of reflection, knowing that there's heaviness, that there is emotion associated with what you just saw. As much as we talk about data and outcomes and numbers, we have to remember that it's not just numbers, that there are people and families attached to these data sets. So I want us to take a moment and think and to feel. First, let's feel first. So identify the feeling. What feeling are you having? And if you want to share it in the chat, you can. If you want to keep it to yourself, you can. You've identified this feeling. Now, my question to you is, what are you going to do with this feeling? And here's the question. How can I use this feeling to propel me to learn something new, to make improvements to my practice, to make my patients and their families feel heard? And so you can keep that for yourself if you'd like. You can put it in the chat to share if you'd like. But I want us to take additional steps beyond noticing what we're feeling and thinking about what we're going to do with that next feeling. So thank you. So now what do we do about the futures? Well, we all know this figure, this ubiquitous CanMeds figure, in the same CMAJ set of issues that were focused on Black health, there is commentary from authors and colleagues who have done a lot of work in this field. And so there's one here that's titled Anti-Racism as a Foundational Competency, Reimagining CanMeds Through an Anti-Racist Lens. And so I would recommend, if it's something you're interested in, look at what these authors have offered as ways to integrate this into training. There's also the concept of structural competency, and this is an idea put forth by Dr. Metzel, who wrote Protest Psychosis that I had mentioned earlier, as well as Dr. Helena Hansen, who train psychiatric residents to act on social determinants of health and institutional racism. And so they have multiple publications that give instructions to educators about how to integrate this into teaching. There's the idea of cultural safety, and I hope now that we've gotten past ideas of cultural competence that was already kind of going out of style in the 90s, but replaced with the idea of cultural humility, that we're never going to have 100% perfect understanding of culture, given that it's amorphous, it's changing, that it's specific, but that rather we can have lifelong learning and reflection on our assumptions and recognition of power imbalances. And through building on that learning, we can move from a place of awareness to being sensitive, to being responsive, and ultimately making spaces that are safe. If you are interested in more specific learning about this, I am really excited about this Black Health Primer course that's coming out from the Black Health Education Collaborative. And I did run into a couple of them on the weekend, and they said that this is coming out very soon. So if you are keen to learn about this or share it with your learners, I would keep an eye on their webpage, because this primer looks phenomenal. There are different streams of learning based on where you're at as a learner, and even based on identity. And it's a course on Black health and anti-Black racism for students and faculty and educators. And it's going to be available across Canada in both English and French. So that's pretty great. If you are looking for some on-the-ground clinical experiences, I can't say enough of good things about TAIBU Community Health Center. So I currently work with TAIBU, sometimes giving community talks, but also doing clinical work at a satellite site. And this is the only community health center in all of North America that was designed with the Black diaspora in mind. So African and Caribbean patients and clinicians are front of mind at the center, and we still see everyone, but this one has specific focus on culturally safe care. And so there are such great projects and ideas, initiatives coming out of this organization. I can't say enough good things. One of these things is the mobile crisis teams. And so across the city of Toronto, there has been really big success with the adoption of mobile crisis teams through community crisis services that divert calls from 911. So right now in Toronto, if you call 211, you will be directed to this different service, and instead of having police involvement for mental health crises. And so the data that's come out already and the ones that are about to come out are really, really outstanding. So as you can see here, successfully diverted 78% of calls received from 911 with no police involvement. So the numbers are pretty big here. And my role as a psychiatrist in the clinic is basically, if the mental health team and outreach team, the social workers have done an assessment, think that someone might need psychiatric assessment, they have an easier pathway to get to me as a psychiatrist. And then when the group is affiliated with a community health center like TAIBU, they can also see a family physician who could provide the referral or do other medical care needs. So that's pretty exciting. And I think the sign of it growing is the fact that there's going to be more and more of these centers opening up in this coming year. So other bright spots for the future, I have to acknowledge, especially if any are on the call right now, Black Medical Student Society, Black Medical Students Association of Canada. I know there are chapters in provinces across the country, but I am so heartened to see what young learners have come up with and put together. And so there are great organizations if you're looking to get connected, if you're looking to learn more, if you're looking to be uplifted, that learners themselves have organized. So I think that's just wonderful. And in addition to that, like Natalia had said, there was a pretty big conference this past year, the Black Physicians of Canada's inaugural conference. And to be honest, we couldn't have done it. Nobody could have done it without Natalia. Natalia made that whole thing run. So I wanted to say a big thank you to you, and also note that it's not just physicians who have an impact on Black health. We cannot do this work without all kinds of professionals and skill sets. And so we need you and we thank you, and you're having an impact on Black health futures. So thank you. So we've gone through some pasts, some presents, some futures. I hope you have some ideas percolating about things you want to connect to in the future. And with that, I want to say thank you for having me today. Thank you for your attention, and I look forward to our discussion.
Thank you so much, Dr. Sahlu. That was phenomenal. I'll invite everyone to turn their cameras on so she can see her lovely audience. We've got a couple minutes. I have a few questions that were submitted prior to our conversation today, but does anybody have a question that they would like to ask right now? Okay, so one of the questions said, what's one of your most surprising, positive, or recent learnings?
Surprising.
While you think about that, I'll answer.
Yeah,
When
yeah,
you
yeah.
mentioned Negroidism at the beginning of the presentation, I was like, because I had never heard of that term. I've heard about like Blackness kind of like as a pathology, but I'd never heard that term before. So I'm grateful to have that that language being shared, and that's something that I can kind of like draw attention to in future educational opportunities.
Yeah, it's so wild when we think of like the darkness, the dark-sidedness of the history of medicine, and not just psychiatry, also obstetrics and gynecology, like the dark history there, especially with Black women and brown women who were experimented on. And so I think for me, the surprising, it's hard to say surprised. Unfortunately, I think there's a level of perhaps cynicism there, but I did go to a Black reproductive health talk a few months ago in Toronto, and pretty much everyone in the room had fibroids. Pretty much everyone in the room had endometriosis. And it was just hands up, hands up, hands up, hands up around the room. And I think the surprise at not knowing, like, the data, we kind of know the higher rates, but seeing it in real life in a real room with real people, I think was pretty shocking. So I think what's surprising to me is like the actual numbers, I think, are probably bigger than they are for a lot of things that are not as well studied as maybe some other areas of medicine that get more funding and attention.
I agree. We've spent a little bit of time just exploring how much medicine has centered white men as the only example of like what a human is, and how inadequate that has been. And so I think that hopefully as that becomes more of an area of focus, all of these populations that haven't had their due attention will start to learn more about their health conditions, and also, you know, have the opportunity to heal and to avoid and prevent those kinds of conditions in the future. We're right up on 1:30. So again, I just want to thank you sincerely. This was beautiful and really thought-provoking as well. There is a survey link in the chat. And so if you enjoyed today's presentation, please make sure that you fill out the survey so that we can make sure that we're always meeting the needs and people's interests. For our DSA book club next month, we're going to be reading White Fragility. And so we'll spend a little bit more time kind of delving into some of these topics related to anti-racism and allyship. And anyone who is a student, faculty, staff in the College of Medicine or staff in the SHA is welcome to join us for that. And you can find more information on our website. And next month's webinar is going to be on March 22nd, so you can look for more information in your inboxes soon about that event as well. And thank you all for joining us, and I hope that you enjoy the rest of your afternoon. And happy Black History Month. I forgot to say that at the beginning.